It's very, very intimidating, it's very humbling, but I guess here we go. I'm going to take you on a journey. And I want to take you on a journey through history. The history of our specialty in a lot of ways, the history of Marco Godina, but also my own, and put things into context and into perspective. And the story really doesn't begin in the distant past. It begins on November 17th, 2022, and it started the day before my birthday when I received a phone call from President Joan Lipa, who informed me that the Godina committee had selected me as the 2023 Godina Fellow. It was after a day in clinic, my heart dropped. I recall exactly how I felt, and I can recite every word that was spoken during that conversation. I was 43 years old at the time, and I mentioned to John that I could not help but remember that Marco's life was tragically cut short at the age of 43 on February 7th, 1986. And so I kind of jokingly, but somewhat also sadly, said, hopefully I'm not going to die before tomorrow. He said he would have an incoming fellow who prematurely would passed as well. So it was a little bit of a saddening, but also a very, very humbling feeling that filled me at the time. But who was Marco Godina, this larger-than-life figure that became a giant in reconstructive microsurgery? Some of the characteristics described to him were his tireless energy, and I think if you think about the fact that between 1976 and 1983, he performed over 800 microsurgical reconstructions. That is amazing, particularly when you take the history of the context. It would be amazing today, but back then it's almost outlandish. He was somebody who was described as having impeccable logic, and I hope that I can show that over the course of the talk today. He was someone who had boundless optimism, which I think he must have had, given that he had a pretty high flap loss rate at the time. Initially, it was approaching 40%. So that, again, puts things into perspective when we're talking about a giant of our specialty here. And he was someone who had constant humor and was courteous at all times. And that becomes evident in hundreds of pages of correspondence that I had the privilege of reviewing over the past year. I obviously did not know him personally, so I'm not going to pretend I knew Marco Godina, yet I was very familiar with his work, and much of which actually served for me as an inspiration during my training, but also today. And his work was introduced to me by my very first plastic surgery teacher at the University of Freiburg, Professor Stark. He was the chairman at the department in Germany, and he printed out Godina's articles for me to review in my first month of internship. So that was kind of the way that I was introduced to the subspecialty of reconstructive microsurgery. And so when you think about this, and when I thought about this, I thought that the ASRM membership can be divided into broadly three different categories as it pertains to Marco Godina. Those like myself that knew him through study of his original contributions, he actually read word for word what he did and what he reported. Those, the more senior surgeons that knew him personally, and the younger members of the organization who knew the legend of Godina by way of the Godina Fellowship and the unbelievable accomplishments of the preceding Godina Fellows, but perhaps without really granular information of who he was, what he stood for, what he actually did. And so I thought it might be worthwhile to reintroduce Marco Godina and his accomplishments to the membership with an eye towards the more junior folks, and to introduce the person, the surgeon, to the membership. Well, there is always an obligatory baby picture. Marco was born April 15th, 1943. He was delivered in secrecy, and he lived with foster parents for the first 2 years of his life for political reasons. And he was then, fortuitously, if you will, reunited with his family thereafter. He was educated in Ljubljana, former Yugoslavia, now Slovenia. He was multilingual, and that certainly served him well to maintain correspondence with friends and colleagues internationally in later years. He developed meningitis in the late 50s, and during his recovery, he developed an enthusiasm for medicine. And given that he had experienced how it was to be a patient, he then developed a very patient-centered approach of how he delivered care and how we actually designed clinical studies moving forward. And that can be seen throughout his career. He went on to medical school in former Yugoslavia, was awarded for his work on cleft lip. So for the younger folks who are contemplating about cranial facial surgery, there's still hope for you. Finally, in 1971, he started his plastic surgical training in Ljubljana, and here's his original letter of intent that he wrote in response to the job ad that he had outlined. that also contains information regarding his salary, which was nearly 500 dinars difference between his salary as a physician in training and a receptionist with language skills in German and then one other language. So what this shows you is that we all start very, very small, and we can only grow when we have friends, supporters, an environment that allows us to leverage talents that we have, ambitions that we have, but certainly nothing happens in a vacuum. And 4 people were instrumental in shaping his career, impacting his life, and those 4 are shown here, all of them giants in the field of plastic surgery: John Cobbett, Bob Acklin, Ian Johnson, and Graham Lister. But before I go into the detail about the relationship of these with Marco, I would like to express here my sincere appreciation to Isha Godina, his daughter, who I had the pleasure of meeting when I was in Ljubljana. And initially, that lunch meeting was scheduled for an hour, but that ballooned up into a day and a half, where she showed me the beautiful city of Ljubljana, the house, the building where Marco was born, the building where they grew up as children, she and her siblings, and it was just an incredible experience. It was kind of living history, if you will. She also shared with me pictures and correspondence, hundreds of letters that he wrote to other famous individuals at the time. And so that was obviously very meaningful. I would also like to extend my sincere gratitude to Urosh, shown here left in the picture, who is the former chair of the Department of Plastic Surgery, so a successor of Marco, as well as Clement, showing the top picture of this team, the current chair, who were just incredible hosts during the visit. So going back to John Cobbett, Marco developed his interest in microsurgery. He was actually initially interested in burn surgery. He developed his interest in microsurgery when he visited Cobbett in East Grinstead in the UK in 1972. And here you can see how he's thanking John Cobbett in a letter where Cobbett had encouraged him to connect with Bob Acklin, whom Marco met in 1973 when Acklin was merely a registrar, so a resident essentially. And the lesson learned here is that you meet people during your training, and these people during your training that you engage with, they can become lifelong friends, and oftentimes they do, and they become advocates for you. So it pays off to be nice. It pays off to utilize and leverage these platforms that you have to engage with individuals. And here you can see that Acklin is already advocating on behalf of Marco Godina with his boss, Tom Gibson, to get him a spot at a canvas burn course. And so you meet somebody and then you advocate for them. They went on to have a very close friendship and exchanged really many letters. And it's kind of a discrepancy because Acklin was very verbose. He wrote long letters, and Marco was more short. But either way, it was a very close friendship, it seems. And here Acklin is commenting, among other things, on the need to keep a balance. And so my ears lit up a little bit, but unlike today's work-life balance discussion, he was referring to balance between clinical and research. So the life aspect perhaps came a little bit short in the 70s. In other extensive letters that Bob Acklin wrote to Godina, views regarding the United States, some flattering, some not so flattering words shared, in addition to technical tips for vascular anastomosis, developments in terms of instruments for microsurgical procedures, but also words of encouragement and advice for Godina on how to deal with failures and how to deal with his chief. So we're talking about Marco Godina, who clearly must have had failures, who disclosed those to Bob and then received encouraging words. So we all need those individuals in our lives to push forward. The relationship with Ian Jackson was that of a very close friend, whom Godina would also send patients to for craniofacial surgery. And it was very interesting for me to read how this giant in plastic surgery, who has textbooks published, readily disclosed that he had no idea what tangential excision for burn injuries was at the time, and that he needed to further his education in this regard. And what this tells me is that they had a very high degree of honesty, that there was nothing pretentious in their relationship. And I think that was something that was certainly very fruitful for Marco. And finally, Graham Lister, who's essentially considered the cheerleader on behalf of Marco Godina on the United States side of things, former ASRM president, notably in the year that the very first Godina Fellow, our very own Larry Coleman, had the honor of representing this award. Lister also led the efforts for compiling Godina's work and publishing it as a thesis that you can see centered here. And he also encouraged the landmark papers of Godina to be published posthumously in the September 1986 issue of PRS, and I encourage all of you to review those. This thesis is, I believe, a must-read for any reconstructive microsurgeon, and I'm grateful for the team in Godina for having given me a copy. In fact, much of what I will show today is taken directly from this thesis and is put in the historical context, if you will. During the 1970s, Godina maintained close contact and correspondence with many plastic surgeons, and he visited centers in the United Kingdom, Sweden, in Austria, and Germany, thus enhancing his surgical training and experience. And all this resulted in him developing an overwhelming clinical experience that allowed him to propose solutions to clinical problems. As such, he was really one of the first real clinical researchers whereby his clinical activity translated into scholarly productivity with tangible offers in terms of solutions for clinical problems. And in this 1979 paper, for example, he essentially presented a how-to guide to perform anti-side analysis in the context of microsurgical reconstruction. It is very interesting that in the early series, where he did end-to-end, his complication rate approached 38% of flaps done. In the subsequent 41 patients, he did all of those at the side, and then extrapolated from that you should be doing at the side. Today, one would perhaps, as a reviewer of that manuscript, think maybe there's a learning curve bias involved in that, but nonetheless, those are incredible numbers considering historical context. Perhaps most importantly, Godina readily acknowledged those that impacted him favorably. Here he is acknowledging Graham Lister, how Graham Lister's observation of descriptions that Godina gave him helped him interpret the findings, as well as acknowledgments of Bob Hackman. What was really meaningful to me was the ability to review his manuscript drafts. So the original drafts that Godina had written, the way that he kind of crossed things out, it was very interesting because it allowed me to get a peek into his mind, how it worked. His focus on timing of reconstruction is quite clear when you look at this, as well as this very algorithmic way of looking and analyzing reconstructive challenges and proposing solutions derived thereof. He described the saphenous flap, for example, when he was developing a microvascular model in a dog that first used it clinically in 1979, subsequent to which he published it collaboratively with Bob Hackman in 1981. And importantly, Godina was very self-critical, as evidenced by his assessment that the importance of this flap is perhaps very small. And turns out it was right, the saphenous flap never really took off. The importance historically, however, cannot be understated because this was only the second axial pattern skin flap that had been described, subsequent to the dorsalis pedis flap. And Godina had hoped that contributions like this would stimulate investigation into the vascular anatomy of skin flaps of the lower limb, and he was right in that regard. This publication is perhaps what many of us associate with Godina, the spectacular case of an ectopic implantation of an amputated part. And again, Godina readily acknowledged that the idea for this approach actually came from R.K. Daniel, and it was not his own. He was just somebody who executed on that idea, on that discussion. Members here today, you may have seen a lot of this degree of surgical mastery from this guy, 2010 Godina Fellow Jim Higgins. His landmark paper certainly was on the effect of timing of reconstruction and its outcomes pertaining to infection rates after lower extremity trauma. And certainly the concept of early coverage is justified. Having said that, I don't think that we need to cover defects within 72 hours or immediately even, and this is something that our president, Joe Hipag, touched upon yesterday, because Godina did not have the advanced wound care strategies available to him, like negative pressure wound therapy dressing that we have today. What he would do is 3% bore test for wound coverage and wound care. So whenever we interpret research, clinical research, we have to take into account the history when interpreting those findings and see whether those things are applicable to today's clinical practices. Nonetheless, impressive numbers, impressive way of looking at clinical problems. The truly innovative concept of Marco was, and that was cemented by his vast clinical experience, was the importance of a combined collaborative approach to lower extremity injuries. And whenever I think of collaboration between orthopedic surgery and plastic surgery, one name really comes to my mind, certainly in 1997, Godina Fellow, in 2006, ASRM President Scott Levin, who I have the privilege to call a mentor, a teacher, and most importantly, a really close personal friend. As I mentioned, the importance of teamwork, collaboration, is a thread throughout his work. Yet, Godina expressed concerns that this level of collaboration is still an exception, even in developed parts of the world. Well, I would say that as a specialty, we've certainly come a long way when you consider that the theme of our meeting this year is collaboration, and it certainly is something that is at our core. So we certainly have evolved. And indeed, today, complex microsurgical reconstruction is offered from coast to coast, from Penn to the Monkey Clinic and everything in between, and countless centers that offer these complex procedures, securing that patients that come with injuries such as this are treated successfully. This was a 14-year-old boy who was transferred to Stanford with a complex lower extremity defect. And I don't have to go into the principles of this, but you do debridement, you cover it with antibiotics. And in this particular case, we have to perform a reconstruction by means of creating an AV loop with end to side to the femoral vessels because of lack of suitable vessels in the vicinity, ALT flap transfer, and that provided for stable soft tissue coverage that allowed us to then successfully complete the reconstruction. I should say that very few things are more meaningful to me personally, and I think to many of you, regardless what subspecialty you go into within micro, when you see a patient of yours walking in on a limb that you help salvage long-term after the reconstruction is completed. Now, this importance, or the importance of limb salvage, was already recognized over a century ago by George Fowler, who famously stated, "Any fool can cut off a limb, to save one is a true scientific triumph." And speaking of scientific endeavors and aspects of our specialty and activities, it's important for us to not only perform complex procedures, but also share the experience and lessons learned so that we can all collectively push the field forward. Having said this, it was for me a coming full circle experience when I was invited back to go to Penn Medicine and reconnect with my teachers, Scott Levin, ASRM past president Joe Soletti, close personal friend Suhel Controlla, Steve Kovac, Josh Fosno, but also having had the opportunity to connect with the junior faculty, Saeed Azuri, as well as numerous other faculty at the Penn Flap course, Dr. Erdman, Milan Stefanovic, just to name a few. An interesting discussion in Godina's thesis is on the issue of mechanical devices that would eliminate the surgeon's tremor, the development of which he believed had been in vain. He's talking about vessels between 1 and 3 millimeters. Turns out, much has changed over the past few decades, with novel robotic systems being investigated for eliminating tremor, granted for vessels at a smaller scale, sub-millimeters, but those are the developments that we see. And certainly, critical assessment of these novel technologies is important to determine what their role might be in the context of reconstructive microsurgery in the future. And so to learn more about these systems, I visited the University of Maastricht, where the Microsure system has been developed, and I had the opportunity to get some hands-on experiences with this, and I thank Shanshan for supervising me that I don't damage that expensive device. But in addition to that, I visited the Trauma Hospital in Ludwigshafen, where I saw the Somani system being used in a clinical setting and had the opportunity to see my friend Luis Kinza perform a lower leg reconstruction using this technology. Now, visiting Ludwigshafen had another significance in the context of the Godina Lecture, and that was Godina had visited Ludwigshafen in the 70s himself. And here are the letters of Godina in his chair asking and inquiring about visiting that hospital in 1973. Godina's go-to flap was the latissimus flap. Well, it was a flap that was first published in 1906 by Canzini and was largely forgotten thereafter until Nathan Olivari from Cologne, Germany, rediscovered it and reported on its use in 1976 for the treatment of radiation ulcers of the chest. Godina went on to present it as to be the first to present the free latissimus flap for lower extremity reconstruction at the German Society meeting in 1978, the year I was born. Fast forward 21 years, and we get to the landmark publication by our very own Dr. German, also ASRM past president, who reported on the versatility of the subscapular system in the journal. It was particularly meaningful to me to receive his invitation last year to attend the annual meeting of the German Society, the same society meeting where Godina had presented the free lap flap decades before, which was hosted in Heidelberg last year, and where he served as conference president. Here are some impressions of the meeting that was really organized to perfection and provided an unbelievable platform for exchange. And I think for the younger members, perhaps part of the beauty of our specialty is that it is fairly young, thus giving us the ability to really touch and interact with the pioneers that really have shaped our specialty. An example is in this photograph. Next to every matros, you have Hans-Ulrich Steiner, which was Gunther's mentor. So now you have multiple generations in an image. And right next to him, Edgar Biemer. Some of you may know him, others may not. He was a pioneer in replantation surgery in Germany in the 70s, and someone who directly corresponded with Godina. These are letters between the two from the 70s. I should mention that numerous ASRM members, such as Joan Lipa, Babak Marara, Babak Safa, Kyle Evelyn, Renee Largo, Paul Soderna, the list goes on and on. It was almost like an ASRM meeting last year in Heidelberg. All were present there, and it demonstrates the society's investment and commitment to maintaining these collaborations and these interactions with members in the United States, but also abroad. And it was wonderful to see that on full display. Going back to Marco, it is important to acknowledge that despite his accomplishments, he was a human after all, and we all sometimes can be wrong. Such as this, he was of the opinion that diabetic ulcers were not amenable to microsurgical reconstruction, and that inguinal flaps, groin flaps, were associated with incredibly high complication rates, and that we should not be doing that. Well, 2015 Godina Fellow J.P. Hong convincingly demonstrated the contrary, perhaps a great example of how the student outshines the master. To the left is JP when he visited University of Pennsylvania when he was a Godina Fellow, and to the right is JP and I both as Godina Fellows at the Duke Flap course just this past year. Speaking of the Duke Flap course, I would like to thank Brett Phillips, Jeff Sisk, Kristen Rizak, Jeffrey Marcus for the kind invitation to visit the university and attend the Flap course. It was truly a wonderful experience, and I congratulate them for having continued the legacy and the tradition of this very important educational event. In his thesis, Godina disclosed his realization that microsurgery was only part of the complex treatment of extremity injuries, and that other important factors have to be addressed to successfully reconstruct the limb. While the same can be said about many other aspects within micro, such as also post-mastectomy reconstruction, where microsurgical success, that is flap survival, really does not tell you that much about the clinical outcome that the patient has. Both cases here on a sterile table are microsurgical cases of success. Flap survival is fine, they have no donor site morbidity, yet the aesthetic outcome is obviously vastly different. So there are numerous other factors that have to be considered when we perform and offer reconstructive services. So the notion that the microsurgical aspect of any operation is only a minor part, a micro part, one might say, is also evidenced by the fact that we have flap loss rates in the context of breast reconstruction of sub 1% today. So other challenges have to be taken into consideration, and these include sensory loss of the breast skin envelope, nipple loss, poor projection, a panel that we had on yesterday, partial breast defects, as well as perforator mapping, and I'm briefly going to touch upon these. The importance of sensory restoration of the female breast has been acknowledged widely, and something that 1998 Godina Fellow Phil Guardiola already commented on in the 90s. Yet, significant heterogeneity exists with respect to surgical technique, method of measurement, timing of measurement, a multitude of things that prohibit you from being able to convincingly perform quantitative comparative analyses or meta-analyses. And that was demonstrated by Anna Zoe, my former resident and current MD Anderson microsurgery fellow. However, published literature does seem to support the notion that sensation occurs earlier in time and is of better quality when you offer patients neurotization of the flap. And as such, we felt that given the heterogeneity, that there was a need to perhaps standardize an operation. And we proposed a procedure or a sequence of events that was characterized by technical simplicity and minimal donor site morbidity, amongst others. But what was particularly rewarding was the ability to collaborate with close friends, such as Ivan Ducic and Urosh on this. And again, Urosh is the past chair of the Department of Plastic Surgery at Ljubljana. And so there, another connection kind of came about. The flap is harvested in a very standard fashion, lateral to medial, until you see the nerve fibers emanating from the rectus sheath. Following incision of the rectus sheath, the sensory nerve branches dissect the retrograde and distal to the sensory motor Y junction. the sensory nerve is clipped. Thereby, you preserve motor innervation to the rectus muscle. The length of the nerve that you obtain in this fashion is rather short, and so in my practice, I have to use rigid material to make up that gap. While different options exist for the recipient nerve, my preference is to use the third anterior intercostal nerve, as described by Godina Fellow, a nerve that has demonstrated to have comparable sensory nerve axons as the lateral intercostal nerve, which is widely known to be the dominant nerve to the middle areola complex. In order to prevent any disruptions in the flow of the operation, I'd like to perform the proximal nerve palpation first to a nerve allograft, then the flap is transferred, microvascular anastomoses are performed, and then I perform the distal nerve palpation, so it doesn't really impact the flow of the operation, it doesn't change ischemia time, and everything works very, very smoothly. I should mention that before you perform the distal nerve palpation, it's important to trim that nerve allograft to have the shortest nerve allograft possible that yet allows you to perform tension-free coaptations. And whenever you investigate or propose a new surgical approach, it is important that you rigorously study it. And in this study, we looked at long-term outcomes, and we were able to see that protective sensation occurs to a significantly greater degree in 8 of 9 tested regions of the neurotized breast. Fortunately, I should say, the interest in flap neurotization has increased substantially in recent years, and the leader in this field is Stefania Twinder, a surgeon scientist from the University of Maastricht, who I had the privilege to visit, who's truly a phenomenal surgeon and an incredible researcher. I was able to see her surgical approach to autologous breast reconstruction and engage with her and her research team. And I should say, I talked earlier about the microsurgical system with robotic microsurgery. Now Maastricht is coming up again. The density of talent there is quite remarkable. And so thank you again for hosting me during my time there. Another important aspect of breast reconstruction is preservation of the skin envelope. The quality of the skin envelope that is left behind makes up over 70% of the final result that you have. So improving approaches that preserve the skin are certainly worthwhile to pursue. And the favorable impact on nipple preservation on breast aesthetics is self-evident. You don't need to run multiple trials to demonstrate that. You just have to look at a picture and see it just looks more natural when you preserve the entirety of the skin envelope of the organ you're trying to reconstruct. Yet a number of factors exist that have prevented nipple-sparing mastectomy to be offered widely, including concerns related to nipple necrosis and nipple malposition in the context of breast psychosis and macromastia. A particularly meaningful manuscript and study that I reviewed was published by Mihai Choi and Nolan Karp from NYU, who demonstrated in a large number of patients that if you perform breast shaping procedures preceding a nipple-sparing mastectomy, that none of those patients developed nipple malposition. Well, given their expertise in breast reconstruction, I was really thrilled when I was invited to visit NYU. After spending time with the team, engaging in discussions with the residents, the fellows, Mihai, Nolan, Ed Rodriguez, and others, we went to the cadaver lab. And the dissection must have been very difficult, or the anatomy must have been very aberrant, because the facial expression was somewhat peculiar when I reviewed the images thereafter. So maybe I have to reach out to NYU again. I don't know what exactly is there. But based on the experiences of Nolan and Mihai, we expanded the concept introduced by the late Scott Spear of breast shaping procedures preceding nipple-sparing mastectomy to see whether we would be able to expand the indication for nipple-sparing mastectomy. So if you were pushing the envelope in that regard in the context of autologous reconstruction. And that curiosity resulted in this study being conducted with close friends, Sohel Kutrala from the University of Pennsylvania and Anis Katani at the time at UCSF. And in 61 patients that we included, we performed 122 reconstructions, and we had a nipple loss rate of less than 7%. And mind you, these are patients that, based on conventional criteria, never would have been offered nipple preservation to begin with. So certainly for those individuals, it was moving the needle in a favorable direction. An example of a patient is shown here. She has some brestosis, 49-year-old, cancer on the left side, lumpectomy, oncoplastic reduction, and then bilateral nipple-sparing mastectomy reconstruction with autologous tissue transfer. Now, once we had experience with normal BMI patients, we then pushed the envelope to offer the same concept to patients where, during my training, we never even would have considered offering nipple-sparing approaches, but we deployed the same concept, breast reduction, and then nipple-sparing mastectomy and autologous reconstruction. Now, certainly, the results are decent, but when you consider where we started, it certainly is an advancement compared to what I had learned in my residency training. My former fellow, Lauren Daly, published our preliminary results with this approach in the obese population, and since then we've included a number of additional patients, currently 41 and 82 reconstructions, and have observed a nipple loss rate of less than 10%. Mind you, these are in high-risk individuals with a BMI greater than 30. On the opposite end of the spectrum, we have patients with borderline donor site volume, resulting in postoperative results characterized by poor projection. In fact, we had a wonderful panel yesterday with Raj and others discussing exactly this topic. And certainly you can perform bipedical abdominal flap transfers. It's simple in the unilateral situation, but if you want to do this bilaterally week after week, it is very, very difficult to scale. And so in those cases, my preference is then to perform a very simple operation, which is a combination of implants and autologous reconstruction. I would like to acknowledge Sarah Surice in the audience who provided these illustrations here, in addition to a lot of emotional support in the process there. The soft tissue coverage that you obtain in using this technique that covers the implant is quite robust, as demonstrated here. But naturally, patient selection is critical, and the ideal patient to offer in hybrid reconstruction is somebody who has donor site laxity but lacks sufficient volume. And when you take that into account, I think that it is a good example of how this approach truly expands autologous reconstruction to patients previously not deemed good candidates. From a technical perspective, it is as easy as you can imagine. You just perform your abdominal flap transfer, or thigh-base flap transfer, or lap flap, whatever it is, and then you put the implant under it. So it's technically very simple. The pedicle is very long, it slides over the implant. You can take a bite of the mesh that covers the implant and secure the implant to the chest wall exactly where you want it, and all you do then is drape the flap over the implant. And the laxity that you have at the donor site really allows you to have complete anterior coverage of the device. Representative outcomes are shown here in a 47 and 48-year-old patient, and when you look at outcomes that you can obtain here, I think it is safe to say that there are panels now at numerous meetings talking about aesthetic breast reconstruction, and we are able to deliver on that promise where oncologic treatment and aesthetic results are no longer mutually exclusive. You really can combine all of those. A question that arose in the early days was that of safety. Does the implant impinge on the pedicle, kink the pedicle, or anything of the like? But we were able to hopefully convincingly demonstrate the safety of this in over 110 reconstructions. So hybrid reconstruction thus expands the reconstructive offering and allows for an individualized approach based on patient preferences rather than anatomical restrictions. A particularly challenging patient cohort are those with partial breast defects, frequently within a radiated field, and as such I look forward to visiting an expert in breast reconstruction, Mustafa Hamdi, who's written extensively on this topic in Brussels. It was really a tremendous honor for me to visit his apartment, interact with his team, and then most importantly be able to scrub with him and learn pointers from the master, if you will, intraoperatively. And following my return back to Palo Alto, I was able to immediately implement and deploy some of those lessons learned clinically in my own practice. So I'm very thankful for him for that. When we discuss patients with our trainees preoperatively, we discuss and stress the importance of preoperative planning. And in the context of microsurgical reconstruction, perforator mapping is part of the homework preceding any procedure. And traditionally, we've been using Doppler ultrasound. We've heard and we have had the opportunity here to look at the more novel imaging technologies, duplex, and other elaborate ways of identifying the vascular tree. These modalities, however, are operator dependent, and it takes some time for you to acquire the skill. The most commonly used imaging modality preceding breast reconstruction is CT angio. That was introduced a number of years ago by John Garcia, who is also in the audience today. Yet a CT angio, or MRA for that matter, is a 2D representation of a three-dimensional structure. And perhaps for the younger folks, for the residents and some of the fellows, it's very difficult to extrapolate that onto the patient, what you see on the screen. And so we posed that question: how can visualization or interpretation of those findings be improved in the educational setting? And so in the first step, we used CT angio data and fed it into a 3D printer and got models. And I'd like to thank Eric Jablonka, former Microsurgeon at Penn, and at the time craniofacial fellow at Stanford, who led efforts in this regard. Having these 3D models, it gives you the patient's anatomy so that the anatomy can really be grasped preoperatively. The vascular topography can be understood, and it facilitates perforator selection because you have the model in hand without having to make the single incision. We then proceeded with leveraging AR technology using the HoloLens system in close collaboration with Dr. Bruce Daniels, professor of radiology at Stanford. And I'm grateful to my resident Dave Chomok, who led a project investigating spatial fidelity, as well as my postdoc, Fabian Mecca, who optimized the workflow of transferring CT angio data onto the HoloLens that allowed transfer of this technology into the operating room, where we then performed a number of studies and projects looking at accuracy, time of perforator mapping, and many other questions in that regard. The use of the HoloLens system is very, very simple. It's a simple drag and drop. It allows simple alignment of the virtual model onto the patient. All this is scaled. And precise alignment is possible and allows assessment of the patient's vascular anatomy prior to any skin incision being made. The speed of perforator mapping, when we actually studied it systematically, was superior to any ultrasound-based approach that we compared it to, and the accuracy was really spot on with the positive control, which was the 3D model. And it correlated clinically, not just with the model, but also with what you found intraoperatively in terms of where the perforator exited the rectus sheath. Well, it doesn't just predict where the perforator exits the rectus sheath. That is easily seen intraoperatively. One may ask the question, is that at all necessary to get imaging for that? But it predicts the subfascial course of that perforator, thus simplifying flap harvest, and it expedites the way that you can get the flap up. The next iteration is to use smart devices, such as iPads rather than the HoloLens. Readily available suture packs can serve as landmarks to align the model and also get the depth just right. And while the necessity for this technology for experienced surgeons is perhaps legitimately questioned, I would argue that the opportunity for improving the learning process for our trainees certainly has to be explored, leveraging this technology and getting more engagement so that we kind of maintain that high level of enthusiasm amongst our trainees. And speaking of learning, I would like to share with you my beginnings in microsurgery. This is my first free flap that I did in 2005, and I say I did, that's a big stretch. I was a PGY2, the attending allowed me to do some of the micro. He probably did the micro and made me feel I did the micro, I'm not quite sure, but I'm standing by this is my first free flap case. The faculty whose room I entered looked like this. He was less than enthused that I was the only resident walking into that room. I was very motivated, I wanted to do the case, but here he is 18 years later, Olga Banosh, who I'm indebted to and who has become a close personal friend. And for those of you who think that German professors are always mad-looking or angry, he actually had a pretty good time at the ASRM meeting last year, so I really thank him for everything that he has done. I certainly wouldn't be here today without him. I should also mention that he allowed me to help him significantly during the case and also allowed me to do the micro on an ALT flap, a flap that neither he nor I had ever done in 2005. And our preparation for that was this article, Have We Found the Ideal Soft Tissue Flap? Authored by the one and only Fu-Chan Wei. Well, I had read the manuscript in 2004, and in my wildest dreams I never would have imagined I would ever meet him, yet alone be hosted by him at Chang'an almost 20 years later. So that was obviously incredibly meaningful to me. It was a remarkable experience to meet Dr. Wei and the faculty at Chang'an. The institution was even more impressive than I had imagined from articles and reports about this. But what struck me, I never would have imagined, was to sit at his desk, have him review his clinical cases and his clinical study results with me, share his wisdom with me, and his perspective on his specialty, on his experiences and lessons that he had learned. Certain new friends were made, and I had a wonderful time connecting with past Godina Fellow Jonas from Sweden, Chang'an faculty Jamie and Johnny, as well as the numerous microfellows such as Alan. Obviously, while in Taipei, I visited 2006 Godina Fellow Mingwei Chen, certainly needs no introduction, a pioneer in lymphatic reconstruction who leads an impressive clinical operation in the heart of the city. And I would like to state congratulations to him again on this new venture. Next stop was MD Anderson, where I was greeted by two previous Godina Fellows, Ron Yu and Matt Hamilton. My very close friend Ed Chang, as well as an impressive cadre of faculty and residents. It seemed like a natural transition to go from Chang'an to MD Anderson, because I consider Ron to be the person who really popularized the ALT flap in the United States. I should also mention that throughout my training, I read articles, numerous articles that were published out of MD Anderson, but also MSK. So coming from Germany, I was pretty agnostic. It was two massive cancer centers. And numerous of those articles really impacted me and helped me not only get trained better, but also articles that I go back to even today when I see clinical problems. Such as this one on multiple simultaneous free flaps for head and neck reconstruction, so that when I saw this patient, a 7-year-old with a combined cranial defect and facial defect with exposed brain and sinuses, etc., you know that reconstruction of these are possible if you just take a systematic approach to this. And in this case, we did AV loop to the neck vessels, ALT flap transfers, and we're able to get soft tissue coverage, and I did this operation with my close friend, Derek Wong. And here's the kid long-term presenting to discuss revisions. Speaking of Memorial Sloan Kettering Cancer Center, the Godina Fellowship I would not consider complete without visiting this premier institution. The caliber of faculty is really second to none, I should say. On a single slide, you have past, incoming, current presidents, you have the future program chairs, Charles Nelson and Robert Allen Jr., an incredible pool of talented fellows, but most importantly, I feel very fortunate to call many of them my close friends. Over the past year, I thought a lot about my personal journey to the United States, and it all began with passing the examinations for the ECFIG. And I recall when I was going through the process that I was always looking up to someone who, from my vantage point, had done it all, at Harvard no less, and is now the chief at Yale University. And so I considered it a privilege to be invited and then to visit Bo Tomahawk at Yale and to engage with his remarkable faculty. The connections within our specialty are what make it so special. At Yale, I then connected with Harvey, who's the former MSK fellow, as well as Dave Poland, son of the first Godina Fellow, Larry Poland, who was my junior resident when I was a micro fellow at the University of Pennsylvania. So here you can see all the connections that happen with just one surgeon's life, if you will. You're touched and you touch numerous lives in this context. Yale is special to me also for another reason, as it was a Yale School of Medicine graduate who really made my dreams of coming to the United States a reality. And that's Jim Chang. It was almost 17 years ago when he visited Freiburg, and he was the Bunnell Traveling Fellow. And while he was not really particularly encouraging at the beginning, all the pieces fell into place. And eventually I ended up being at Stanford. He was instrumental in my matching at Stanford, no doubt. And certainly he was the person who recruited me back as a faculty to Stanford. I sincerely thank him for everything, as well as saving me a lot of dollars at the barbershop, because I clearly lost up my hair in the process. It is really not every day that one puts a talk like this together, where it's not just a show and tell of what you do clinically, but you get to really take a sit back, think about your life, and think about what makes that life meaningful to you, something that transcends your clinical practice and your research pursuits. So you take inventory, and you consider what really gives meaning to your life. And there are multiple concepts, multiple books that have been written. This I found very meaningful to me, that describes 4 pillars that contribute to a meaningful life: belonging, purpose. I think we all share to some level of similar purpose, transcendence, and storytelling. Talking about one of these pillars, belonging, there is a strong correlation really between the sense of belonging and the perception that life is meaningful. And I think if you really think about it, it just makes a lot of sense. And the feeling of being supported is by people other than your family that leads to a greater sense of meaningfulness, right? And so I am certainly blessed to count among my closest friends. This is my family outside of my immediate family. People like Babak Safa, who needs no introduction, our president-elect. These are my brothers, Babak, Suhail Kushwala, one of my closest personal friends. Greg Bunke, hardly a brother, more like a dad, if you will. Rudy, who we all know as Uncle Rudy in the Bay Area, and maybe outside. Sarah Sariche was really a sister to me, my true. Evan Matros, who shows off his hairstyle and shows me what I can never accomplish. Rich Venosa, who goes the extra mile to really follow my, to have the same hairstyle as I. And then partners like Eric Juan and Chuber said, I couldn't really ask for better people along the way. I'm also blessed to count amongst my close friends and a strong network of mentors at Stanford, people seen here. My chair, Mary Hahn, who obviously is ultimately my boss and signed off on my getting the faculty appointment at Stanford, and has been nothing but supportive since I arrived there. Mike Romiker, who needs no introduction, I think, in this forum. Similarly, Rod Hens, who needs no introduction. Tom Crummell, who's the chair emeritus. He's the first faculty when I visited Stanford as a visiting medical student 22 years ago, who I scrubbed with because I was on the pediatric surgery service. And Sherry Red, who's the chief of the VA Palo Alto, who basically signed off and supported me coming to the United States when I was a visiting medical student to Stanford. And you could not come to Stanford without faculty vouching for you. I had sent her countless emails, did not get a response, called her office, did not get a response. Ultimately, I paged her in the operating room. She called me back. And so her only comment was, resilience pays off, and then she signed off on it. So I'm not encouraging you to bother me in the operating room, but if you do, there may be something positive that comes up if you want to come to Stanford. Individuals may also gain a strong sense of belonging through activities in professional societies, such as ASRM. I think it provides an incredible platform to do so. It has done for me, that gave me the platform to visit incredible institutions such as University of California in San Francisco, and congratulations to Scott Hansen for his new appointment there, or the Baby Trauma Hospital in Frankfurt, visit friends in Singapore, as well as the University Hospital in Vienna. The final stop of my Godina travels was a week ago, actually less than a week ago, at WashU, where Justin Sachs was just an unbelievable host, has grown the division of plastic surgery really considerably. It oversees an impressive operation and an impressive cadre of trainees and faculty. And thank you again for the very kind invitation and for hosting me in St. Louis last week. Engagement in professional organizations and using it as a platform is something that characterized Marco's activities as well. And seen here are some of the meetings he attended and program booklets he kept. And he furthermore cemented his commitment by actually joining those societies. And you can see here the acceptance letter from Dieter Bukampo of Godina to the German-speaking Society of Hand Surgery. It is noteworthy that the German Society for Reconstructive Microsurgery was founded in 1977 at that meeting, at the Hand Surgery Society meeting. And seen here is a delegation of the German Society of Microsurgery at the meeting last year, as well as Anna Bosch, who came all the way here this year. And so the fruitful international exchange clearly continues to this day, and I think this is a platform that we can expand upon. Among the many things that make the Godina Fellowship so special is this sense of belonging and belonging to an impressive group of people displayed here. Many of them are my teachers. Lisa Wu, who became a very close friend. Safa, who needs really, there's nothing else that I can say that I haven't said already. But also meeting new people like Jan Brax, who's one of the nicest guys you can meet. And I'm not sure if I would have met him as easily as I did, not having had this platform. So when I think about the future, I really am encouraged and optimistic as the talent that I saw during my travels will surely take our specialty to new heights. And looking at faculty like Hari at Yale, Danielle at MSK, Marissa at UCSF, Carrie Chu at MD Anderson, I mean, the talent is extraordinary and it's really unbelievable. I think we're in a really good place. We heard today that our financials are in good condition. I think our talent pool surpasses that by multiple degrees. Folks like George and Chris, who already have made an impact on the specialty with the inaugural and truly unforgettable meeting on plastic surgery innovations, and there's going to be more to come, is my understanding. I already blocked off the dates. What I'm most excited about, however, are the fellows, residents, medical students that are about to launch their careers. I see their enthusiasm, I see their intellect and their passion, and that convinces me that our future really is bright. The manifestation of that enthusiasm may be different than what my approach to learning was, but their enthusiasm is, I think, the same and even greater. So I do believe that our specialty is in the best of hands. On the last couple of slides, I do wish to thank ASRM, the selection committee, for providing this platform of exchange. I really have an experience of a lifetime, and I'm eternally grateful. One key aspect of the fellowship is one that John already mentioned, is that you are an ambassador for the society. And during my fellowship, I had the privilege to visit 11 countries and 18 programs. But when I finally visited Ljubljana, I had the tremendous honor of meeting head of state of Ljubljana, President Natasha Kirtmusar. And I'm happy to share that following our discussions, she agreed to host all future Godina Fellows that come to Slovenia at the Presidential Palace. And I believe that that experience will further enrich the experience of any future Godina Fellow who takes upon him or herself to travel to Slovenia. And I am happy that I could at least play a small part in providing that deliverable to the society. So thank you for that. Last but not least, I would thank my family. And without these people, I wouldn't be here, so thank you.